you to the December meeting of the Long-Term Care Planning Committee. Because we are recording this meeting to be posted, it would be great if you could keep yourselves muted unless you're speaking. And then when you unmute yourself, if you could just say your name before speaking, that would be extremely helpful. Because we are still one shy of a quorum, I am going to recommend, let me just pull up here our agenda for today, and I will screen share it with everybody. I'm going to make a proposal to flip our agenda a bit in the hopes that people come and we can move our votes to the later part of the agenda. So our agenda right now is to let's see, maybe this is our quorum. No. So rather than having all our votes up front, I am going to propose that we amend the agenda and bump up the DSS annual rebalancing update presentation to the top of the meeting after I do roll call, and then proceed with number 2 and go in order from there. Is anyone willing to make that motion?
So moved.
Thank you, Michael. Second?
Second, this is Amy Porter.
Thank you, Commissioner Porter. Any discussion? Okay, all in favor, please say aye.
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 Anyone opposed to the change in the agenda? Great. Then we will proceed with roll call, and then we will hop right into the DSS annual rebalancing presentation, and then get into the discussion of the long-term services and supports plan and vote on the recommendations to follow, and our 2025 meeting schedule. We have to adopt that today as well. So with that, I'm going to call the roll. Let's see, Christine Weston. She's here.
I said here. You didn't hear me say here?
Oh, no, I didn't hear you. No.
Oh, well, I could have wonky sound sometimes. I'm here. Hello.
Glad to have you. William Seals. Margie Gerundo Marquette.
Here.
Kelly Kendall.
Kelly is not
Levitz.
able to attend today, Melissa. Thank you.
Oh, Krista, are you in for her by chance?
Yes, I thought I'm actually the
Oh, well then we
person
will
representing
just
GDS.
replace that and make that good. All right, good. We have quorum, but we will, since we already voted, we're going to move with our original plan. Okay, Barbara Cass. And Commissioner Amy Porter.
I'm here.
And Jessica Rival said she's going to be joining us late. Lisa Rivers. Michael Santoro.
Here.
And Laura Watson.
Here.
Oh, fantastic. Hi, Laura.
Hi.
I didn't see you on my screen. But,
Melissa, this is Erin Levitt-Smith. I didn't hear you call my name, so I just wanted to be sure.
oh, yeah. Yep, I got you. Thank you. Okay. With that, Christine, I'm going to turn it over to you and your team to provide your annual Community Options Rebalancing Initiative update.
Sure. Hi. Good morning, everyone. Very happy to be here. Absent the 5 years that I took off, I used to present at this committee annually and always love giving the updates on what we're doing in community options. So for those of you that don't know me, my name is Christine Weston. I am the Director of Community Options at the Department of Social Services. Our Community Options unit handles all of our home and community-based services, either regardless of funder, right? So we do our CMS home and community-based waiver services. We do our state plan services, our Money Follows the Person program, and all of the ARPA 9817, which were designed for HCBS, was living in our unit. So this report's going to touch on a number of areas. I've also brought a number of our staff to that are the leads in those areas to kind of give more detail, present their slides, and be available for questions. Happy to take questions throughout the presentation if that's easier. We're going to be talking about a couple of different chunks of topics, so happy to take them right as we're moving along. Also want to thank Melissa for giving us some grace and extending this. I think we normally do this over the summer, and moving us to the December meeting was very helpful for us to kind of get organized. I had just started in May, so this is better to do it now. So thank you, Melissa. All right, so we're going to get into our deck. We have 4 presenters today, myself, Randall Wilson, Michael Pecorelli, and Anna Carabin. They'll introduce themselves as we join. Randall is one of our, RJ or Randall, however you want to call him, he'll say it doesn't matter, is our Community First Choice Manager over the 1915K State Plan option for Community First Choice. Michael Pecorelli on Friday will be our new manager over HCBS integration and Money Follows the Person. So I'm very thrilled to announce that Mike is coming on to the management team at DSS, longstanding MFP staff, and also worked at one of our contracted access agencies. So very happy to have him. I think Friday is your official day. And then Anna Carabin also starting on Friday as manager over our newly formed quality assurance and provider engagement piece of Community Options. So for those of you that are, key stakeholders for us or longtime contacts or need questions answered, I will share some of our leadership changes. We've had a lot of vacancies for a very long time, so very happy to start building out the Community Options team. So I will move on from there. Where's that screen? So we're going to cover 3 areas today in our presentation. We're going to cover Money Follows the Person, which of course is our flagship foundational rebalancing program that we've had for years, but also Community First Choice that we're now in our, I believe we'll be starting our 11th year of CFC, which was part of our home and community-based expansion supports to divert individuals from nursing home stays prior to institutionalization through MFP supports. And then the American Rescue Plan Act, or what we call ARP 9817, which was the funding allocated to the department to enhance home and community-based services through additional federal funds. Okay. So MFP, for those of you that are long-term on this committee, we have the same data that we track longitudinally for years now. Our data goes back to 2018, and we like to kind of capture information for trends to see if there's things that we need to be doing differently. We have 5 benchmarks that we'll review in the next 2 slides on what we're doing, and then the other item we'll talk about is some changes that are going on at CMS around Money Follows the Person, and let you guys know kind of how the department is taking the approach that CMS has asked us to kind of modify how we do things. So this is just referrals over time. So the top number are the referrals, that we send out, that we screen and send out to the field. So when we say referrals to the field, those are ones that we have screened in the department and have sent out to an access agency or one of our sister agencies to do an assessment on. And then the lower number is the number of transitions by each quarter. So you can see we had a fairly slow start to 2024. We are trending upwards, which is nice. The holidays tend to also produce a lot of transitions. There's people that really want to get home before winter and to get home before the holidays. So I am hoping that our last quarter numbers are high. And you can see like it's kind of, there's always a demand, there's always a need, there's always a constant churn of referrals going out to our contracted access agencies for assessment. And our transitions do dip at times, but again, over the past 2 or 3 years, kind of steady across the quarters. This is our transitions by quarter. So just making sure there's no hands. All right. So benchmark 1 is total transitions. So this is total transitions for the life of the program. And we're at 8,275. The difference between demo and non-demo is just really an indication of the CMS guidelines and the funding for Money Follows the Person. There's some nuanced rules that we can still support individuals to transition to the community. It's just if we can count them, it's like a technical count. So we've made a commitment in the department that if people still need our support but may not meet all of the check marks to be considered MFP eligible, we still support as much as we can to support them to transition to the community if that's their choice. Other benchmarks are ones you've seen for a while, and they're really very telling, and it tells a very interesting story in Connecticut. We were very excited the year our numbers crossed, which was in 2017, so I'm looking at benchmark 2, where our Medicaid long-term care expenditures were greater for those in the community than those in institutional care, which when you're thinking about rebalancing, right? The concept of rebalancing was that we should be spending equal, if not greater, dollars in the community for people to have choice and control over their services rather than institutionalizing them when we can meet their needs in a setting of their choice. Of course, people choose institutional care as well. It's just not everyone's choice, and that they should have options on how their Medicaid funds are spent. So you can see we had a trend, 18, 19, 20, they were fairly close. And then in 21, we had a big separation of cost. And then, is that 21? Yeah, that's how the numbers were. That's 2020. That's a weird graphic. Okay, so that's 2020. And then we're dipping down again. But also, it's very important to overlay that chart with the chart next to it, which is the amount of people. Oh, wait, percentage of. Oh no, Anna, wait, where's the other chart? The percentage of people home. No, pause the presentation for a second. Okay, sorry. Benchmark 5. We're going to jump so I wish it was on the same slide. I thought it was the same slide. The benchmark 5 is the receiving services in the community versus institution. So although we're having similar costs, we have far greater percentages of individuals in the community. So we're at 69% in 2023 of those receiving LTSS supports paid by Medicaid. We're receiving them in the community versus the institution. So you may see some movement in that cost of care and some variation, but we are serving far more people in the community, which is very important when you're thinking about choice, control, and quality of life, and how people get to say how they receive their services. So that's an important graphic. This third graphic is percent of hospital discharges to home and community care versus skilled nursing facilities. So what we're tracking here is the people that if you go in for an unexpected hospitalization, that the care plan team at the hospital is not saying, okay, well, you're going to have to go to short-term rehab, or you need to go into rehab. It's making sure that you have the services and supports back home, especially identifying if you already were connected to HCBS services, or if there is something we can put in place temporarily while we get you involved in a waiver or some other higher level of care by Medicaid. So that's a great number as well. We like to see that for people to be able to go from home to hospital to home and not having to take a short-term rehab stint, which what we hear in MFP is, most of the people that are referring to us went in via short-term and then got stuck. Something happened. They didn't have the person-centered holistic care planning to get them home, and they got stuck, and then we're supporting them to get home. I'm talking very fast, but there are still no hands raised, so I'm going to keep going. This statistic, percent of nursing home admissions returning to the community within 6 months. Oh, can I put Julie or Deb on this spot? I don't have the background on benchmark 4. Julie, did I see you jump on? Sorry, I'm tagging in our Yukon Center on Aging staff. I thought I saw Julie. Sorry.
I'm here.
Oh, she is. Okay.
Yep, I'm here.
Can I just tag you in on benchmark 4 just so you could more accurately describe it?
Yeah, you bet. So it actually comes right off of the point you just made, Christine, where we hear a lot about people who go in for short term with the plan that they're not staying, and then they get stuck. And so this is the percent of people, all SNF admissions, so not long term, not just everything, that actually come back out again in the first 6 months. Because if they go in and stay in for 6 months, then they're really stuck. So this is tracking from 2010. We saw in the earliest years of MFP all the way through 2017, the percentage increased. The increase is good, so that means more people are going home, even if they do go to a nursing home. And then over the last 4 or 5 years, it has kind of stabilized at around 35%. And so it's better than we were doing in 2010, but it's not a huge change. There's definitely room for improvement. This is one of the benchmarks that's really delayed, because first we have to wait 6 months from a person's admission, but also we use claims data to look at this, and claims data, nursing homes actually have a full year to submit their claims. They don't usually take that long, but we like to wait about 5 months to make sure that all the nursing home claims have been submitted. So there's about an 11-month delay on this one for how far we can look back.
Thank you.
You're welcome.
Okay, moving on, we've already talked about benchmark 5. So when we talk about our benchmarks, that's the data that we've been evaluating and tracking since the dawn of time in MFP. So very valuable data, especially when we're trying to think about what we need to do differently, what's worked well, what hasn't, and we're constantly referring to those kind of data sources. The other stuff that we highlight in our reports that we think it's important to share with people is kind of the quality of life surveys that we take, and when we touch base with the individuals that transitioned, what we're hearing from those individuals. So there is a whole host of reports, and maybe Julie or Deb can drop it in the chat. We publish all of this through the UConn Center on Aging. It's excellent information. I also love, we have personal stories that we share about people that transitioned that just really kind of validate why we do what we do. So the happy question is always an interesting one. You know, at 1 month and 12 months, we ask, are you happy or unhappy with the way you live your life? And this goes back to what I've been kind of repeating in all of the slides. MFP is about choice and control and where you choose to receive your services and supports. So our goal is to hopefully that they are happy upon discharge, and then 1 year later that their services and supports remain, are still stable, they're good, and they're happy. So we love this kind of anecdotal, well, it's actually very official data, but we like it as like something to report out to you guys to say like, hey, we're doing good work, right? So when people look at us, we don't just do the bare minimum, right? We're trying to improve people's experiences. We're trying to improve a quality of life. And this happy chart has always made us happy in the program. So that's MFP benchmarks and our data analysis and what we've done to date. The look ahead at CMS, CMS has challenged us that they now want, oh, there's a chat. Is that a question or? Oh, no, just the reports. Thank you. So CMS has recently asked that all of the MFP states start presenting 12-month short-term goals. We have these huge operating protocols and these grand plans on how many people are going to transition and how many people we're going to help as a state. But they want some really hyper-focused 12-month short-term goals that we can then report out to them, like, you know, do you need support with planning? Are you going to need staff or funding for this? Like, what are you going to be asking us for in your budget? And what are you working towards in the state? So some of this came back through as we were defining these short-term goals, and they're not yet approved by CMS, but we've talked it out with them. We really looked at information we've heard from our public. We had gotten some feedback from the Ombudsman's office. We were at the Voices conference a few months ago, and some of the residents gave me some feedback on MFP. There's enhanced funding opportunities at MFP that he basically went to the states and like No one's asking for the money. Can you all figure out a way to get this money? There's money to be had. So that's one of the short-term goals I'll get into. And the others are some of the things that we're just seeing on a national level as well as a state level about workforce. So our first goal is we're going to be providing informed choice through information sessions in skilled nursing facilities, which is going to model close to our closure process. So right now, people find us, right? They find us either through the facility social worker, word of mouth, if they see a case manager in there with somebody else, if they're Googling ways to get out of nursing homes, they find us, right? It's passive. We're not doing as much in reach. What we've also found is that people are coming to us maybe a little too late, or maybe they don't really know what they're asking for support. And it would be much better if we could routinely inform directly by the department the residents in these nursing homes and give them direct information and what it means to participate, and then take those applications. So when we go in for a closure, Anna, who is our closure lead, deploys a bunch of social workers and care managers, and they talk to everybody. And it's called an informed choice, and it's a push-in, and they talk to everybody about what their options are. And then we either have people apply and say, I want to move on to the process and get an assessment, or people decline and say, I'm good. You don't need to talk to me. So we're going to pilot and model that moving forward, because although you saw our referrals were steady, which I don't want to make anybody sick, our referrals are steady, but that doesn't mean they're being referred at the appropriate time or in the best opportunity for us to serve them. So we're going to pilot this, and we're going to track to see if like our push-in informed choice process, if we get them home sooner. And if we're doing a service to them where we can maybe increase our transitions because we're getting people earlier. So we'll be able to report out on that. Well, this is going to CMS for approval at the end of this month. We've already talked to them about it. I'm sure it's going to be approved, and then we'll be able to report out as we start collecting information on that. No questions. Okay. The other issue is MFP. So the demonstration at CMS added funds to help people transition quicker that were waiting for subsidized housing or rental assistance vouchers by covering at 100% reimbursement up to 6 months of rent. And that's really interesting for us, because there is our lease up process and our process to get people into housing can be delayed. But if we could, but they have their services, they have their natural supports, but we're working on kind of like the federal paperwork and all that other stuff. If we could do that in tandem while they've already transitioned, and we have up to 6 months to do all of that, that may also speed up our transitions in the length of stay that they have to be in the nursing home, what we hear waiting for MFP. I like to use air quotes. And I hate that people are waiting for us, but the honesty is there's a lot of complexity with Medicaid eligibility, rental assistance programs, and such. This was found, through all the research and analytics that the federal government was doing on MFP, and said, hey, we're going to cover rent for you. Get them home. Maybe they know you're going to be reached on the wait list in 3 months. Don't make them sit in a nursing home for those 3 months. Let them go home, and we'll pay the rent, and it'll be reimbursed. So that's huge. But we can't just ask for that money. We have to develop a feasibility plan. Will we have buy-in from landlords? Do I have the housing supports built into the program? Because the other issue is you better have a funding source after 6 months, because you can't transition them home and not have a solution for the 7th month and ongoing. So what we've been asked to say, like when I said, well, can we just put this into the budget now and start testing it? They said, nope. Why don't you put in one of your short-term goals to be a feasibility of building a housing plan to use the enhanced funding? So we're going to tap our housing staff at DSS, our housing coordinators at the contract agencies, and some technical assistance through CMS MFP to kind of build out a housing plan. We all know that affordable, accessible housing in Connecticut is a tremendous barrier, but if we could also get through one of the loopholes of like our paperwork processes and our administrative burden behind some of this and get people home faster, I think that'll be a great short-term goal. The last of our short-term goals that we'll be presenting to CMS is just continuation of our workforce development through building out the career pathways for PCAs and other in-home supports. So if you follow the legislation in Connecticut, there's been a lot of legislation around career pathways. The Office of Workforce Strategy is doing a lot of work with all of the health and human service agencies to kind of build an educational place for people to kind of land and train and learn and make sure that we have the workforce to support the growing home and community-based population. So My Place CT has already done a start. We've started teaming with DDS, ADS, and I believe DOL is in that work group, and we're trying to build out for not just PCAs, but other in-home supports, and really just have like kind of a no wrong door for people that are looking to get into this line of work. So one of our goals is going to be to kind of support that workforce development and carry on some of the initial work we did under a public act through legislation, and now we'll continue it through an MFP short-term goal. Because if we don't have staff, if we continue to transition hundreds of people every quarter and we don't have the workforce to support them, that's another delay to transition while they wait to be staffed up. So I talked a lot. I'm sorry, Melissa, that was longer than I thought, but and we have a few more things to get through. Any questions on MFP? Okay. Community first choice. So now we're going to turn this over to RJ or Randall to go over our CFC numbers, some highlights about the transition to our fiscal intermediary, and our collective bargaining agreement with 1199. So go ahead, RJ.
Thanks, Christine. Good morning, everyone. Randall Wilson, or RJ for short. So community first choice, part of the 1915K state plan option. This program has grown exponentially since its inception back in 2015, I believe, Christine, 2014, one of the two. Yeah. But the numbers here are straightforward, so we'll dive into them right now. So CFC in total, there's 7,033 active Medicaid members that are actively receiving services from the program. How this is broken down, though, specifically is we have 2,971 individuals that are active with a waiver. Those waivers are noted on the right hand of the PowerPoint. And then 4,062 members that are actively receiving solely just the state plan benefit itself. The waivers numbers are broken down by waiver specifically. So ABI 1 and ABI 2, both 53 each respectively. The autism waiver at 16 individuals. Connecticut Home Care Program for Elders, which is our biggest waiver population that is accessing the benefit, is at 1,285. The Katie Beckett waiver, which is for children ages at 76. The P, which is for individuals 18 to 64 at 769. The Department of Developmental Services, which is serves individuals with intellectual and cognitive disabilities at 701. And then Department of Mental Health and Addiction Services and the mental health waiver at 18 respectively. So these numbers, again, are in total for the members that are accessing the CFC benefit within the state. Our understanding and our predictions are that ultimately this program will be growing exponentially by 10% each year. So we're looking at around by hopefully 2026, 2027 that this program will be serving members upwards of 10,000, if not more. Any questions on that? No? Okay. Christine, if you can move forward with the next page, please. All right, so now we're going to start talking about our fiscal intermediary. So as everyone knows, Allied Community Resources was our main fiscal intermediary that administered the Community First Choice program and the other DSS waiver programs from 2014 up on to 2023. As of March 2024, we now have a brand new fiscal intermediary, GT Independence, that has assumed all payroll and non-payroll activities from Allied after a 6-month period of onboarding. being completely transparent, we have recognized as a department that the transition from the FIs, it has highlighted some administrative and programmatic issues, but we are actively mitigating all of those and have a plan in place to move forward in a positive aspect. There was an increase in grievances specifically from the PCA union, SEIU 1199, and complaints from members during the initial 6 months. But again, DSS, DDS, and GTI have all worked together to resolve these issues. And most recently, we actually had a 2-day summit between all entities to discuss some of these problems and again, come up with a plan to move forward in a positive trajectory. And when it comes to the collective bargaining agreement specifically, again, this was a agreement that was made between SEIU 1199 and DSS. There are 2 wage increases that have occurred in 2024, and then there's going to be another increase slated for January 2025. PCAs will look to see that increase in their wages beginning on January 1. PTO implementation. As of March 2024, PTO has officially been enacted with the PCA union. So now members their staff are eligible to actually utilize PTO for given reasons such as sick or vacation or personal time off. In addition to that, there have been 2 additional holidays that have been added to the holiday calendar for time and a half pay, and that is going to be Juneteenth, which is June 19th, and then Labor Day. There is a premium assistance payment change from semi-annual to annual. This is very important to note, just because of the simple fact that, excuse me, at one point, people were under the assumption that it was going to be semi-annual, but that is not the case. It is annual. And recently, we held a work group meeting on qualifying life event side letter, and this was held between members of DSS and 1199. Christine, if you can move forward with the next. Oh,
Yeah,
Melissa,
it's
go ahead.
Melissa.
Yeah.
Go ahead, Melissa. Melissa,
No,
I
I'm
told
sorry.
the team, make sure this was immaculate because you were gonna catch something. What's
No, it is immaculate. That's not, I just wanted to pause here and take a moment to just acknowledge that for members of the Long-Term Care Planning Committee who may not know, so the collective bargaining agreement is actually between the PCA Workforce Council and 1199. And the PCA Workforce Council, since the inception of the collective bargaining agreement, had been housed at the Office of Policy and Management and staffed by our division, the Health and Human Services Division. In July, Christine took over as chair of the PCA Workforce Council, and the collective bargaining agreement transitioned from the Office of Policy and Management to the Department of Social Services. RJ came on in that time, so Christine was new to her role, RJ was new, and they inherited the collective bargaining agreement and all that goes into administrating it. And I just want to call out that that happened at the same time as the FI transition. And I think that you've been doing a spectacular job navigating that. So thank you. But just wanted folks to know that the actual council that negotiates has transitioned and is now being administered by DSS. All right, thank you.
No, thank you
All
very
right.
much, Melissa. I
Thanks,
appreciate that
Melissa.
clarification. Thank you very, very much.
Okay. So from any questions on CFC for RJ before we move into the next topic? Okay.
And if
great.
there are no
11
questions at
minutes.
this very point in time, Christine, I don't mean to cut you off. Please feel free to email me with any questions or concerns that you may have. So thank you, everyone.
Great, thank you. All right, so we're going to move into what we call the 9817 money. This has been a massive lift in DSS. We've had the funds for some time, but there has been significant leadership churn at the department, at DHS, in community options, and we are doing our very, very best to kind of utilize these funds and keep the programs afloat that we can and kind of cut our losses when we can as well. Our partners at CMS have been wonderful. I think we adapt the spending plan and our narrative and our approach. We have multiple pivot plans, but right now we are in a steady stream of work. We have not pivoted significantly in the last 4 months, and we will be running ARPA through June 2025. So the money was time limited, the activity, all of it was it was originally tied to an end date of March. Connecticut got an extension through June, and we are really running through some very remarkable projects and services for our individuals that will just help enhance service delivery and improve kind of our program operations and what we can do for our providers and our members. So I said the 9817 funding was massive. We used some of it through paying through rate increases for some of our providers. I want to just touch on what I decided was what we picked was our project highlights. Instead of going through the entire ARP project, and Melissa, where am I on your agenda? Am I over your time frame? Is this okay if we go through this still? Oh, Melissa, you're muted. Sorry.
No, you're completely fine. You have another.
Okay.
You have another 20 minutes.
Okay, good, because we could talk forever in our unit. So so for I decided to just pick our 5 projects that are kind of like that have the most attention right now, that are fully resourced and really are going to do some really strong, significant work. So the first is the health information exchange and value-based payments work that we're doing with Connie and our HCBS providers. We have some universal assessment enhancements that Mike will touch on. We have an in-home safety enhancement grant that Anna led, and she'll be reporting out on how we did with those grant awards. We are launching Cope and Capable, which is an evidence-based model for individuals to get, for us to put services in place for individuals that need additional support for care of persons with dementia and aging in place, some money for home mods, etc. We'll go into the details on Cope and Capable. And then closing out our PACE feasibility study, which is a 2-phase study that will highlight, we've completed phase 1 and we are launching phase 2. And then when you get the deck, this is a link to kind of our all of our deep dive data on ARPA. Okay, so this is just a high level overview, kind of a cheat sheet. You guys can just reference this. I'm going to have the staff just talk about the individual. So I just wanted to kind of, if anyone wanted just a quick glance on the 6 projects, they're here. But I'm going to just go into the specific individual report out so we have time. So for the health information exchange and value-based payment, and again, I'm going to tag in my partners, Julie. Sorry, Julie, I did not even text you to tell you I was going to be tagging you in, but I'm going to, I may kick to Julie, who's really been in the trenches on this. And man, this is trenches. When I talk about we have statisticians and data scientists and research analysts all helping us build out a proper value-based payment methodology that's defensible and strongly justifiable in how we're going to be issuing these payments. It's been quite a learning experience. So for those of you that don't know, a little orientation to what Connie is and how we're utilizing them for this value-based payment work. Connie is our health information exchange in Connecticut. It kind of just pulls in data from multiple sources and aggregates it and allows it to be manipulated and dashboarded and used for policy decision making, for analytics on patient care, and really just to help support and build a healthier Connecticut. They've been great partners and really are very much committed to helping us with this work. What we built was we built a Connie portal for home and community-based service providers. So these are any of our waiver providers and our home health agencies and our access agencies that serve individuals receiving long-term services and supports in their community. So we created a model to incentivize people to kind of get hooked up into Connie and to participate with some early benchmark payments. And then they're going to have ongoing payments of value-based payments based on some of the statistical stuff we'll talk about under their member health outcomes. So there was initial ramp up, some payments to kind of motivate, train, encourage providers to participate, and then there'll be ongoing payments based on outcomes. So we are still building the platform and kind of figuring out how we're laying out all the baseline data, understanding what we have available to us through the universal assessment, through claims, etc. And we're still moving through it, but we will be targeting for a go live in March of 2025. So all the first round of payments, all the initial planning and cooperation payments have been made. And now the next round of payments will be around their health outcomes for decreasing avoidable hospitalizations, increasing hospital discharges to home and community-based versus institutional settings, and meeting personal goals that we have outlined through the assessment process for our members. Fun fact, Connecticut is one of the first, if not the first state to connect HCBS providers into their HIE. So this is very innovative, really only doable through these ARPA funds, and for us to really be able to start gathering information on the non-medical, like the habilitative service providers that directly inform the medical outcomes of an individual, because they're the ones that are kind of like grassroots day-to-day serving the members. So any specific questions about value-based payments and Connie? Okay. Julie, anything that I didn't hit that you think is important for this team to know?
I mean, I think those are the highlights. Like you said, it's amazing to put all the work that's been done on this into one slide.
Yeah.
And there's more work to do. And we're collaborating with a group from the Yale Center for Outcomes Research and Evaluation to make sure that we get the numbers right and the benchmarks right. We're also collaborating. I don't think you have, maybe just say a word about the goals piece of this, Christine, the work we're doing with NCQA. I don't know if you have that anyplace else, but that's 3 words on one bullet point. That's another massive undertaking. So the National Center for Quality Assurance, NCQA, which is sort of nationally known and looked to develop quality measures for around healthcare. They've been working for, I don't know, about 5 years. I think they have a 7-year plan to develop person-centered outcomes measures that focus on individualized goal setting and how to set those in a measurable way, and then how to assess them. And so that is one piece that then the HCBS organizations will have an opportunity to get value-based payment if they meet those certain benchmarks in terms of setting goals, following up with people about their goals, and also how well people do on achieving goals. It's another kind of a big piece that's being added in here into this whole idea of value-based payment.
Thank you, Julie, for that.
You're welcome.
Okay, so now we'll go into the universal assessment with Mike Pecorelli.
Hi, everyone. My name is Mike Pecorelli, or Michael, whatever you guys prefer. As Christine mentioned before, so I am the business lead with the universal assessment and the enhancements and the updates that we're doing to it. For those of you who may not know, the original universal assessment, when it was created, has gone through a few changes over the course of years, but overall, it's still a pretty lengthy assessment that takes quite a long time for our members to sit through. So with the allocated ARPA funds, we have gone through and we have sat with like focus groups with our access agency staff for the users who, do this assessment every day. We've worked with UConn diligently to really review what is actually needed in the assessment and what we haven't actually used over the course of the years it's been around. So just as you can see on the slide, there are some we created and submitted the advanced planning document, which was approved. We've had the request for quote go out. We have a vendor selected, and we actually have the statement of work that we're just waiting for it to go over to CMS. One of the main highlights is that we are trying to shorten the assessment and streamline it to make it flow better for everybody, because that's one of the biggest challenges that we hear all the time, is that it takes it could take upward to 3 hours to do a full assessment on somebody, especially if you're a new assessor. So we realized how long that was. And we've gone through the entire assessment line by line, question by question, and we've asked, and UConn has been tremendous in this effort, helping us. So we have a bunch of questions that were throughout the assessment noted as optional questions. And so we looked over the course of the year at how many times those questions were used to see if we can actually pull them out. So, out of the, let's say, I think there were 23,000 assessments done last year, and we pulled out all like the numbers for the questions, and some of them had 0.02% of the times were answered over the course of, of those assessments. So we realized that a lot of those questions are not being used and are not needed. We're also working to enhance our algorithm to better improve the outcomes and the measures that we're using to apply budgets to our members. So there's a lot more to come with that. But yeah, so that's really it in a nutshell. We are hoping to implement and start work on this early in 2025. There has been some delays over the course of the year since ARPA started, as different leaderships, different management teams, as Christine stated. So we have been a little delayed, but we are still continuing to move forward with the enhancements and the changes to the universal assessment.
Great, thanks, Mike. Any questions there? Okay. The next two segments are going to be covered by Anna. She's going to review, actually, I think you're doing all three. So rest of the show is yours, Anna. So go ahead, and just tell me when you need me to move forward.
Okay, good morning. Good morning, everyone. Yep, there we go. Okay, so in-home safety, that was a response to the Public Act number 2418 for an act concerning the health and safety of Connecticut residents. We have ARPA funding that home health agencies and access agencies were able to apply to enhance their safety of their staff when going into homes for our Connecticut Medicaid members. And the approvable items for those awards, this is a one-time funding for the ARPA dollars, but some of the approvable items have been emergency response buttons, training, a safety consultant, GPS monitoring, and a dedicated phone line. We had 2 rounds open for application for the awards. The first began early September, and we just closed the last application period late November. But since November 2024, we have been able to distribute over $4 million in funds to enhance workforce safety to the home health agencies and our poor access agencies. Does anybody have any questions on the in-home safety? No? Okay. Moving on to COPE and Capable. All right. So this is regarding care of persons with dementia in their environment for COPE. It's an evidence-based program designed to enhance the well-being of the individual and their quality of life that are living with a caregiver. They're hoping to increase functional independence, activity engagement, quality of life, and a prevention or alleviating some of those neuropsychiatric symptoms. And it's also to improve caregiver outcomes as well, to ensure that we don't have caregiver burnouts, increase the well-being of that caregiver to be able to maintain that individual in the home setting. There's a confident caregiver that's based on COPE principles, providing guidance to informal caregivers. Oop. Uh-oh. Things going on. Oop. Lost you guys there. Can you guys hear me?
Yes.
Oh, okay, something happened with my Teams. Sorry. For the care of older persons in their environment. And then the Capable, the community aging in place, advancing better living in elders. That's a person-centered approach using a team model consisting of a nurse, occupational therapist, and a handy worker to address the home environment, and uses the strengths of the older adults themselves to improve the safety and independence. And some of those projected outcomes are improving independence, safety and health, lowering health costs, reducing hospitalizations, enhancing motivation and self-efficacy, reducing health disparities, and reducing symptoms of depression. I'm not sure if anybody has any questions on this, on Cope and Capable.
So okay, and just from a functional perspective, we've had some logistical issues with getting this launched. We have some regulatory hiccups that OPM has agreed to work with us on. We have about 2 providers that are ready to provide this, but we are going to get them rolling. We've trained them and they're ready to provide these services. So it's going to kind of be like a soft roll. So for the next steps, we expect to have their first care plan with Cope and Capable embedded by January 25. We're going to continue provider recruitment, and then we need to modify regulations, which anyone who's tried to modify regulations and statute in Connecticut know that's not an easy thing, but we will be working on it. So we will be more to come on Cope and Capable, but it's going to be a kind of a soft launch with the 2 providers that are currently eligible to provide services. But the access agencies are being trained up on it. Our nurses are trained up on it, and we'll be ready to kind of do our soft launch. And then finally, we're going to close out our presentation with PACE, which is the Program for All Inclusive Care for the Elderly. So Anna.
Okay, so PACE is a program, an all-inclusive care for the elderly. This is a Medicaid state plan optional service that offers whole person care to individuals aged 55 and over who need nursing facility level of care, but are able to live in their community with appropriate supports. It will provide a coordinated healthcare services by contracting with a fully at-risk PACE organizations that receive capitated payment for each enrolled participant. The feasibility study is underway. There are 2 primary components: a market analysis and readiness assessment. Phase 1 of the report has been completed. The second phase will include a broad scope assessment to include stakeholder engagement and perform a limited scope assessment of existing eligibility determination process for level of care, determination process, capitation screens, counter process policies and procedures to determine readiness and feasibility to implement PACE. And DSS is currently contracted with Myers and Stoffers for this work.
All right, Melissa, and all that is our update on the community options and rebalancing work. Just a piece of the work that's done in community options, but very meaningful and important work to kind of move that needle forward for HCBS expansion and improvement in quality and care to our members. So that's it. Any questions, please feel free, or like we said, email us where to find us.
Thanks so much, Christine and Community Options team. I think that was a very impressive presentation. A lot going on. I know ARP 9817 by itself brought on a host of initiatives and was a very large undertaking. That wasn't always smooth to get going. So very much appreciate all the work you're doing. Also, the look at the universal assessment, I think, is something that folks have been asking for a long time for DSS to review that assessment. So to see the agency taking that feedback and taking a look at it to make improvements and make the algorithm more accurate or is a positive step forward. So I just want to thank you for all your hard work. Before we move on to the next part of the agenda, does anybody have questions for any member of the DSS team? No. All right. Thanks so much. Really appreciate your time, everybody. And now, members, with that, I am going to dive back into the next item on our revised agenda, which would be that we adopt minutes from the September 10th meeting. However, when I went to send all of those minutes out to everybody, I noticed that there were a couple errors that I would like the opportunity to revise before sending it out to vote. So I'm asking if you would mind if we just table the vote on those minutes to the March meeting. In the meantime, I will correct the few errors in the minutes as previously written, and I will recirculate them shortly so that you're not getting them in March and having to remember back to September. So I think they're fairly straightforward minutes, mostly just because the bulk of the meeting was the update presentation. So it links directly back to the presentation on updates from the 2022 to 2024 long-term services and supports plan that is in its final month. So I'll make those few technical corrections, get the minutes out to everybody, and we can vote in March if that's okay. That doesn't require a technical vote to table. I just wanted to see if anyone has concerns about taking that approach. Great. So then we'll use the rest of the meeting. I'm not going to handhold you through all of the revisions today. I apologize that you got them very late last evening. Due to that, as I talk us through the revisions that were made to the recommendations for the upcoming 2025 plan, I want you to feel free to digest them, take a week to review them. Let me know if you have any tweaks. But I am hoping today I can walk you through what we do cover and don't cover in the recommendations this time around. Some themes that I saw and all of the feedback that was received, why some things were excluded or eliminated, and why certain things were added and others weren't. And then just to get a sense from you today, if there's anything glaring I left out that members feel very strongly about that should be added in. So I'll start by saying that we had not as great feedback for this plan as we did for our 2022 plan. I think we received comments from over 40 different community partners and individuals on the 2022 plan. And this time, between focus groups and feedback from community partners, I believe we're in somewhere around half of that number, getting about 20 people to provide feedback. Particularly quiet were our community partners this time around. So we even had trouble where one of the focus groups that we had, actually two of the focus groups that we had scheduled ended up being canceled. So it was an odd planning year. That being said, there were a lot of successes. We started the planning process for the long-term care services and supports plan. As you know, we start that in the spring of the year that the current plan is going to end. So we started planning activities in spring of 2024. We were able to hold 2 focus groups that were comprised of individuals who utilized the long-term services and support system. They were individuals with diagnosed mental health issues and using the mental health service system, as well as individuals and their family caregivers who have intellectual and developmental disabilities. So those are the 2 populations that participated in our focus group. Again, many thanks to our good partner, the long-term care Advisory Council and Michael Werner and Christy Colville for working hard to solicit feedback from Long-Term Care Advisory Council members. We did get feedback from several members from the Long-Term Care Advisory Council, as well from the Commission and the Alzheimer's Association themselves. So very grateful for all that feedback. And we heard from several of the state agencies who are part of the Long-Term Care Planning Committee as well. What was interesting this year more than in other years is that feedback among the community partners and the state agencies sometimes clashed, where a state agency eliminated a priority and a community partner strengthened that priority, which happens every plan year, so you have to kind of balance that out. The other thing was we had a lot more recommendations regarding acute care, which this plan doesn't cover. So we got lots of recommendations about strengthening general Husky, like Husky A, Husky B for children, providing better coverage for certain types of physician services. And that's the type of thing that we traditionally don't put in the long-term services and supports plan. We focus on long-term care Medicaid and the home and community-based service waivers and other state and community-funded long-term services and supports, but not those acute care types of activities. The other lens with which we looked at putting together this set of recommendations was that in September, if you all remember, the Long-Term Care Planning Committee voted that this will be the last year that the long-term care plan will take this format and have the two overarching rebalancing goals. So over the next 2 years, this committee is going to be very, very busy in determining what do we want our new long-term care plan to look like? What do we want the goals to be? How do we want to pivot? Do we need to look broader? Are there better models for statewide planning that exist? ADS and the Age Well Collaborative have been presenting on the multi-sector plan. Is this a good time to start talking about how our planning can work with that? So in knowing that we are going to be sunsetting these two goals and this layout of the plan, we tried to really look at submitted recommendations with the lens of, can this be achieved in the next 3 years? And trying to pare them down. Lots of comments from people that the last plan had too many recommendations, that the recommendations overlapped between the categories, which I have to agree. When I went back, that was definitely a true comment, and that some of the recommendations were too broad to be included. So we tried to eliminate redundancy, recommendations that were extremely broad, or ones that had large-scale financial implications that were very likely never going to happen in the next 3 years. So with that, any questions about the general approach to recommendation setting? And what I'm hoping you'll see as you look at the recommendations is that even if your exact language wasn't used, a lot of people had overlapping comments on, say, the no wrong door system, on training for informal caregivers and how we can support informal caregivers. The move to a universal waiver was very popular this time around. So that was refreshed. So the other thing that we tried to do is take everyone's feedback that was along the same lines and create a comprehensive recommendation that took into account all of the feedback on one particular topic. So hopefully, even if you don't see the exact way you wrote the recommendation, you'll see the the thought behind your recommendation and the meat of it captured in this plan. So with that said, I'm going to share my screen and try not to scroll so quickly that I make everybody nauseous. I just want to give a sense of the scope of the changes that we made. All right, close your eyes for a minute. Here we go. So we started with some general refreshing of language, you know, taking out baby boomer, going to older adults, adding assessment and training for informal caregivers beyond just providing them with supports. Under programs and services, I am going to spend some time here because this is where we made some significant updates, and I want to make sure they're brought to the committee's attention. So again, exploring implementing a universal waiver with eligibility criteria based on need rather than primary diagnoses. That was an extremely common source of feedback. So removed was ensure access to all levels of the state-funded Connecticut home care program for elders. The reason that's removed is because we talk about expanding, we talk about moving to a universal waiver, and then later on in here, we say while moving to a universal waiver that we need to expand access to the existing waivers. So I took out, due to redundancy, just the specific mention of the Connecticut home care program for elders. And then again, because we talk about expanding access and addressing access in general, just took out the need to study the impact of reducing the copay to the home care program. Since we put this in, the copay has been reduced from 9% to 4.5% and then reduced again. And so I think we've made progress in that one. And again, by addressing expanding access to all waivers, hoping that that incorporates that. And if we see any change in the copay, that's something we would be able to capture in an update under the more general waiver recommendation that we'll get to in a moment. And then it was flagged for us by a couple community members to not call out specific programs as much throughout, and also really that what Connecticut is doing is we want to focus on self-direction and person-centered planning. So the changes proposed here that instead of calling out continuing to support community first choice, that we make it more general to support self-direction in our Medicaid programs. So that would encompass our waivers as well as our state plan. So that would be to the extent possible. And identify skills needed for residents of institutions who desire to transition back to the community and provide appropriate skills, training, and resources. That's removed here because you'll see later there's something that's along those lines about helping with transition. So I took that out for because of duplicity. We did leave in strictly because of the statewide, because this was outside of Medicaid funding, the need to expand funding for the Connecticut statewide respite program and DDS in-home and out-of-home respite services. And again, that's because so much of this plan focuses on Medicaid that we did want to continue to call out those specific state-funded initiatives. So if folks have trouble or think that we should remove that or not be as specific, I'm open to hearing that. But this is a legacy one, and I thought in our last iteration of the plan, it would be good to keep this in one last time so we can measure our progress at the end of the 3-year period. And then if it's not crossed out, then they were in the last iteration of the plan. Lots of comments about the need to expand, reinforce, continue to support adult family living model. So that is staying in. As and also the need to continue providing our family caregivers with training and coaching and financial assistance and working with their employers to help avoid burnout. So these are legacy ones that we're recommending continue to stay in based on comment from the community and members. We're removing this specific bullet on addressing isolation of all older adults and individuals with disability living in the community, because it got into abuse and neglect and housing. It was not a very well worded recommendation, and we address you'll see as we move through, we address isolation of older adults and individuals with disability a couple times under various bullets. And we also have a very detailed and robust bullet on abuse, neglect, and exploitation coming up. So then we did get several comments about not losing sight of My Place CT and making sure that we're promoting that as part of the No Wrong Door system. So instead of adding in, and I did this with several things where people suggested things be added to numerous bullets under numerous sections, is trying to have one bullet that sort of captures the overall tone. So added support and promotion of My Place CT as part of strengthening the No Wrong Door system. And when we're out and we're promoting the No Wrong Door and person-centered counseling and training and presenting people in the community with tools available to them to find supports, that in our talking, we also make sure to support and promote My Place CT. And to continue to support not just any funding opportunities for the No Wrong Door, but really focus on collaborative funding opportunities, right? So that all the No Wrong Door partners are working together. And it's not one agency getting funding and then doing their little piece of the No Wrong Door and excluding other partners. Leaving in the perennial bullet recommendation of removing barriers such as insurance, entitlement, reimbursement, and licensing requirements that prevent or limit consumer access to long-term services and supports. And then this was a reword recommendation that we received, that we just drop the support efforts and implement and just dive right into, you know what, state commit and implement person-centered goal setting and care practices. So we made that recommendation. Then we retained the next couple of recommendations. When we get down to providing advocacy and financial support for the increased use of assistive technology, we adopted some suggested added language about also including increased use of basic technology for connectivity to increase, and actually I'm going to change that word so we don't have increase twice, but connectivity to increase access to services, telehealth, and social connectedness. So again, that's an example where, yes, we deleted a social isolation bullet, but that's because I had said we kind of get at that in a few of these recommendations, and this is a good example. Adopting, adding a language revision here when talking about nutrition services and promoting nutrition services and food security through the use of uniform prioritization protocols and also the sharing of updated resources. Again, looking to retain the recommendation that the state continue to support the senior outreach and engagement program to reduce and treat substance abuse and misuse among older adults. Continuing to be something folks flagged as needed is the increase earlier access to hospice services in the community and institutional settings. And we had a new recommendation come in this year to explore adding coverage of palliative care under Medicaid. So added that. That one and I'm open to thoughts on this one because I wasn't sure if that fell more into if that was long-term care, if that falls more under. So Christine, yes.
Yeah, I was just going to say one of your caveats was we're not going to just talk about general Medicaid, but I mean, palliative care can happen outside of an institution, right? And we have some people that we're trying to figure out how to balance waiver services and hospice services and other services. So I don't know.
Anybody have thoughts on this one? And if it meets our plan goals of staying in line with long-term services and supports and not getting into actual medical care and we can be wild and crazy. It's the last 3 years of this version of the plan. If we
just go for it, Melissa.
Yeah. I'm breaking all the rules, even my own. And the other one we added was to explore capacity of community agencies providing long-term services to implement. And again, this is in long lines where I want the committee to discuss this. Explore capacity of community agencies providing LTSS to implement oral health literacy training programs by dental professionals to improve the capacity of consumers and their caregivers to perform their own oral health care. I can make an argument both ways. I could make an argument that I wouldn't put something on oral health by itself in this plan, like the provision of a dental cleaning or something like that, because we don't do that with physician services or anything else. But this seems to be, and if the person who made this recommendation wants to chime in on the intent, this seems to be more that in our LTSS, that our community agencies implement education on this into their scope of services or when they go do a home visit. Michael?
Yes, thank you so much for including that, raising this issue. My name is Michael Warner. I'm the lead aging policy analyst for the Legislature's Commission on Women, Children, Seniors, Equity, Opportunity, also the administrator for the counterpart organization, Long-Term Care Advisory Council. And this issue of oral health is so important for older adults. We've been talking with a number of people, including legislators and leadership from the Aging Committee. We're appreciative it's included in this report. It's going to be also referenced in the Alzheimer's disease related dementias coalition plan to address ADRD in the state, and the comptroller's healthcare cabinet was hoping to be referenced for their upcoming report. And essentially, you guys were talking about the assessments earlier, and thank you, Mike, and the rest of the team from DSS. I appreciate your work on that. Basically, want to have the potentially include a dental hygienist in that process, understanding the impact of the necessity to eat, having all of your teeth. Can they brush them? Should we have training for caregivers? So I'll have a couple bullets, Melissa, that I might send just to hopefully potentially maybe augment it just a little bit. But there's a state compact of dental providers, of dental hygienists that Connecticut could join with other states to allow for workforce to come into the state. So there's all sorts of benefits that come along with it. And we're really hoping to, as part of the assessment too, to kind of separate it out from simply, can they do their own makeup? Can they brush their own hair? Can they brush their own teeth? But really have a serious dental assessment up front as part of this dental medical integration that a lot of different folks are talking about. So I wanted to just make that brief reflection. I'm happy to talk about it further in other places.
Thank
We'll be
you.
definitely talking about it on Thursday, which I'll talk about later on in the agenda. Thank you.
Thanks, Michael. So I think that the question really comes, is that a medical service, or is there a way that we can, and this was my attempt, to try and get at the commission's, because nobody is arguing, Michael, that oral health is an important part of overall health and well-being. It's more because this is a long-term services and supports plan. Does oral health care, where does that fit in, since we don't do any other kind of acute medical care? So this was my attempt at taking this one and trying to get it in. And I hear you about working it into the universal waiver as well as part of that assessment. So what do folks think about just keeping this in, about exploring capacity for education, and does that seem to fit this time around? I'm not sure if when I put all of you up so I see you, if you're now seeing yourselves back because I'm sharing my screen. You are? I apologize. Okay. So I can't see your hand. So Heather, if you're on, would you be able to tell me if anybody raises their hands?
I'd be happy to.
Thank you. Does anybody feel strongly that this should come out? Why don't we start with that? Or any hands?
I don't see any hands.
Okay, so are people comfortable? Please raise your hand if you're comfortable, just show the raised hand on your screen if you're comfortable with this recommendation remaining. Okay. Is Laura Watson still with us? I don't.
Yes.
Okay, is your hand up? I'm having trouble seeing.
I didn't know if I could put my hand up since Michael put his hand up, so I wasn't sure.
Oh, okay, you didn't want dueling hands. No,
I didn't
you're
want it.
technically a member as well. Okay.
Oh, okay. Yeah,
All
I
right,
support
great.
it. Thank you.
Excellent. Thank you so much. I didn't mean to call you out. So we'll leave the recommendation in. Thanks, everybody.
Thank you.
All right. Is there anything we want to talk about? Any questions on the programs and services section and recommendations? Anything glaring left out that folks feel should be in? Any comments at all at this point? Yes. Go ahead, Michael.
Okay, pardon. I know in this particular venue, I'm a member of the public. I just want to, again, thank you for the inclusion of the adult family living program. This is another area of very high interest for the commission at the legislature, for the aging committee, and for the advisory council. And a simple request would just be to add including spouses. My understanding is the waiver that governs the adult family living program is up for renewal in 2025. While it doesn't require legislation to say, can you open it up for spouses? That's something that could be done without legislation. It's something that we are strongly looking at and encouraging others. And the more we speak to folks, the importance of the adult family living program to rebalancing and everything else, I would just simply humbly request to include the phrase, including spouses, right, to be able to participate as eligible providers, caregivers. Thank you kindly. And that also is in the ADRD state plan and was in last year's Comptroller Healthcare Cabinet report and potentially for the one to come as well. Thank you.
So, Michael, this is Christine. Sorry, Melissa, for raising my hand. That is a substantive change, and it goes against everything we actually do in HCBS currently to allow spouses to be paid caregivers. So it would be a substantive change for all the waivers that have AFL, And AFL really needs a lot of oversight and structure right now. So the way it's written, determining future resource allocation policy and programmatic enhancements and potential growth is reasonable from a DSS perspective. I don't know the added language. I mean, Melissa, I don't know if we don't need to have consensus. I don't think we would agree with including it as a call out because there's a whole host of other things that AFL also needs. It needs regulatory, or it needs oversight. It needs stricter audit parameters, agreement on funding and levels. Like there's a whole host of things that AFL needs right now. It's just not as simple as allowing spouses to be paid. It's very complex and requires a lot of permissions from CMS and amendments to every waiver. Just so you're aware, Michael, it's not an easy addition.
May I respond?
Very briefly, and then we do have to move on to the next section, but yes, go ahead.
Certainly, Christine, and I appreciate those comments and reflections. You know, the state made the changes for the waiver for DDS under legally responsible adult. CMS has allowed these flexibilities. States like Vermont, Ohio, North Dakota, Indiana are already allowing under their adult foster care programs for spouses to be able to participate from a number of different vantage points and with a number of different stakeholders. The ability to address hard to access folks in rural areas and other areas, including cultural cognizant pieces, are all aligning that say being able to include spouses is really super important. I understand this is an aspirational request and documented. There's pieces that need to be moved as part of it, but the main through line of the whole narrative is that adult family living program is great. It's not widely known. It could be known better.
Oh, it's widely known.
Okay, so
that's all. Thank you.
Okay, all right.
I just have to
So
move us
Melissa, we
along
don't have
'cause
to, I mean, it's not a joke. It's not my report. You could add it if you'd like.
Yeah.
That's fine.
No. So here's the thing, and this is part, and Michael, you're bringing me to a good, and then I'm gonna have to just ask that if members of the public hold their comments until the public comment section. And I thank you, Michael. I consider you guys a partner in this since you helped to get, so I welcomed your comments. The other lens, and I didn't say this up front, is we are heading into extraordinarily difficult budget times as well as a state. So the other thing we looked at, everybody had all kinds of ideas about expanding programs, adding programs, increasing things. And a lot of that, we have to be realistic, is likely not achievable in the next 3 years of this plan because of the budget times that we're going into. So we're not really in an expand and grow state of mind right now from a budgetary point. We're in quite the reverse. So would it be permissible and would folks be comfortable if we just added and explore adding spouses? It's not a commitment, but it's something that we can, and this is the Long-Term Care Planning Committee. So it's not DSS is going to explore this. It's not a DSS mandate. It's just we would explore if it made sense. And Christine, part of that exploration might be it absolutely does not make sense. It doesn't make sense fiscally. It doesn't make sense with the impact on all the other waivers. Or do you feel very uncomfortable even having it in the plan? That because you are ultimately going to have to vote on the recommendation. So if you're uncomfortable, I want to reflect that.
Yeah, I mean, perhaps it could be part of how you wrote it. Program enhancements like exploring spouses. Like I think it's an example of an enhancement. I don't know if it's gonna warrant like I don't know. It could be softened.
What if
It's
I
fine.
pulled it out of anything
fine.
that says enhancement and make it its own thing that says explore? I was trying to not make it its own thing, to just kind of put it.
Not make it its own thing. Yeah, keep it as.
Does that work or does that not work?
Yeah, that's fine. That's fine.
Okay. All right, great. Other members comfortable? Does that resolve? Okay. All right. Excellent. Any other comments on this section? The program section at this time? Sorry, I keep putting you up to see hands and realize that that doesn't work when I'm sharing. Okay. Infrastructure is the next place where we had the most feedback. And here, starting right off with exploring the development of a multi-sector plan for aging and disability. As you know, Connecticut is exploring moving in the direction of creating a multi-sector plan. This plan is expiring, so it might be the ADS and the Age Well Collaborative have been presenting on the development efforts of a multi-sector plan for aging and disability to this committee. So continuing that discussion and exploring where the state should go with the plan was added. And then again, engaging in coordinated outreach and education efforts to provide unbiased information to Connecticut residents, and added in here that added the recommendation from one of our members that we include the availability of My Place CT as an online tool. So again, just calling out the support of My Place CT. Do folks think this one's duplicative? Coordinate efforts among various entities impacting No Wrong Door. We might get at that. Look at that.
It was earlier in the plan, Melissa. Sorry.
Okay, I thought so. All this.
We talked about the No Wrong Door earlier in the plan, so maybe just checking to see if it ends up being a duplication, just in a different section.
Perfect. Thanks, Margie. Took out any references to the balancing incentive program that are legacy references. And then worked in recommendations about discharge back into the community. We got varying ones on this. So kind of morphed an existing recommendation into work with hospitals to facilitate discharge of patients with ongoing and complex LTSS needs to an appropriate care setting of their choice. And then again, capturing while exploring a universal waiver. So looking to expand the access to our home and community-based service waivers. And then incorporating the comment that we implement presumptive eligibility as defined under Public Act. So that's Public Act 2439, as folks may remember, implemented presumptive eligibility for the Connecticut Home Care Program. So we had received some recommendations that that be fully implemented, and that the impact of that be studied on both the program and on the consumers, or the Medicaid participants, and that we explore the possibility of expanding the presumptive eligibility model into other areas of the Medicaid system. And again, left that as just explore, because that has financial implications. It has widespread programmatic implications. Let's see. Telehealth remains in, looking to enhance telehealth. We made some technical updates to the ADRC and Service Navigator initiative. Greater integration of employment for persons with disabilities. We just took out the singular reference to MFP and made it that we focus on employment and expanding employment opportunities under Medicaid home and community-based services in general. And then all these sub-bullets under this one about eliminating the benefits cliff are all redundant. We covered them in all other aspects of the plan. So I just removed them. I'm not exactly sure why they were in there last time either. All the other recommendations remain the same as from the last plan, that we promote mobility management programs, that we coordinate and grow fixed route and on-demand responsive transportation options. In one of our focus groups, almost the entire 90 minutes was spent on the members explaining their horror stories with transportation issues and not having access to on-demand transportation and the isolation that creates. So these, I think, speak directly to what we received in terms of feedback from that focus group. So recommending leaving those in. Also continue to hear that Medicaid recipients who self-direct their services really need some kind of access to someone they can call with questions about their duties as an employer, and also just in general, almost that they can get through to somebody when they have a question about their employment responsibilities. And then made some updates that we received from the industry regarding the need to continuously review and modify as necessary the CON process for skilled nursing homes, and that we shouldn't just focus on the transition and transform their facilities, but that the certificate of need process be nimble enough to allow for nursing facilities to work more collaboratively with the state, to work more collaboratively with nursing home providers to achieve the goal of the long-term services and supports plan more broadly. So whatever form that may take. And then here, just talking about the capture and reinvest cost savings across the long-term services and supports continuum. That was very general. So it was recommended that we add more specificity with this language to say that we capture and reinvest the cost savings to enhance the availability and capacity of HCBS and to ensure an adequate provider network. So, and that takes out the sub bullet that talks about just reinvesting MFP dollars, because now that we're moving to, there's other ways of achieving cost savings, and we should be creative and not just be measuring what we're doing with MFP specific cost savings. And then finally, I think we're getting toward the end here of this section, which is to support the continued use of Older Americans Act funding and where possible, utilize Older American Act programs to supplement LTSS for consumers who don't qualify for Medicaid programs. So be able to supplement services, either act as a bridge or be able to, for those who are never going to qualify for Medicaid, give them access to some sort of LTSS relief. This was a technical correction. Last plan, we had somebody who felt very passionately that we focus in on spouses under 65. I think we learned that that's really not feasible, so went back to making this broad with the terminology correction instead of assessment asset to explore adjusting Medicaid spousal assessment rules. And then the other new one that was added based on recommendations submitted was to explore incentivizing quality of care and coordination through implementation of value-based payment models. And I think we heard today that DSS is working hard on that one. So, and that's really, I think those are the sections. The rest are going to have more deletions than anything, but that's the section with the added. Do we have any concerns, comments, anything glaring under infrastructure? Nope. Okay. Quality, we did add the recommendation to recognize and incorporate the state plan to address Alzheimer's disease and related dementias. I think it means the recommendations. I'm going to say in the state plan to address Alzheimer's and disease dementias into long-term services and supports. Continue, so continue, remove just some of these things that were quality, but you have either been achieved or we move somewhere else. So explore using a third-party non-state entity to conduct group home evaluations is very likely not going to happen in the next 3 years. Review licensing certification requirements and probate court protocols. That's been addressed. So we removed that one. Expand the scope of the ombudsman to provide ombudsman services in the community. Well, we have a community ombudsman program now, so we removed that, and instead of saying, you know, get that going, we added, and now you need to fully fund it. So fully funding the community ombudsman program was added. And then the other added one under quality was to explore an adult protective services model that responds to abuse, neglect, and exploitation for adults over the age of 18 who have disabilities. We removed the learning collaborative recommendation, seeing as several learning collaboratives happened under the last plan with the bridging, aging and disability, the work done on the multi-sector plan, and I think adding the multi-sector plan one in and reinforcing the need for no wrong door providers to all work together and collaboration among state agencies. I think we kind of hit it this one in other ways. We're keeping in our the need to accommodate non-English and deaf and hard of hearing residents to make sure that they have access to appropriate services and are not subject to isolation. And again, leaving in the study whether oversight and enforcement provided by PSE and DCP are sufficient and adequately resourced to reduce abuse and neglect among recipients of home care services. All right, housing has just about no change because we have all of the same problems with housing that we had in 2022. So all of those are staying. What we removed was to work at this one here was talking about working with the federal government to secure our risk housing subsidies and preserve development funds. I just removed that because we can't control the federal government and you know, again, with an eye on this version of the plan winding down, trying to really narrow our scope and what we're working on to more feasible things. Not that all of this is feasible, but we certainly can't control, you know, the federal government. That's a trickier one. So then increase Medicaid and state funding for home modifications to include safety measures. We pulled that out because work on that has started. And then under workforce is largely the same. And this is the last section that we just talk about, you know, training options and widespread outreach for our workforce, and to try and do a public relations campaign to get residents and students interested in the direct service field. We're leaving all of our other recommendations from the prior plan in because the workforce shortage remains the same issue that it was then. It's still a very big issue. Folks of our self-directed programs, particularly in the IDDD focus group, were very clear that they need access to PCAs when they have a PCA call out or they need emergency supports. What we removed was to promote a model about retraining nursing home workers to work in the community. That's not really, in this state, that's not really a viable option at this time. And then we just removed the specific goal to address the need for skilled and unskilled healthcare to provide stimulation, increase psychosocial health outcomes. We address that in other bullets, the need to really enhance quality of life and community inclusion for individuals at home. And the final bullet that was added was to address digital literacy needs among older workers and unpaid family caregivers to improve access to sector-based skills training and resources. And we left in creating career advancement opportunities and trainings. So those are our recommendations in a nutshell for 2025 to 2027. A lot of people flagged for me that by saying 2025 to 2027, that's only 2 years and it's a 3-year plan, but it's not. It's 3 years. It's all of 25, all of 26, and all of 27. It expires December 31st of 2020. Trust me, every time I write this plan, I have to go back and check that myself. How do people feel in general? You will have a week to make tweaks if there are edits. If you said something and you feel like in my trying to blend it with something else, I lost your intent, you can certainly let me know. At this point, I'm hoping we don't have any more substantive changes to make to the recommendations. Do folks feel comfortable taking a vote today to adopt them with just minor tweaks and edits that might come into like spelling or how something, things of that nature? Or conversely, what we could do is what we did a couple of years ago during COVID. Everybody voted, emailed their vote in and CC'd the entire planning committee after they had read the plan. So I'm open to either method of voting. So if folks could, I'm actually going to just take, how would folks like to proceed? Are there any opinions on if people feel comfortable voting now? Would anyone like to put a motion on the table to take the vote now, or conversely put a motion on the table to do a written vote via email let's say next Tuesday?
This is Amy. I guess I'm leaning toward waiting because
Okay.
while I think you did a great job reviewing it, I think when you try to think about it all in its
Yes.
totality and kind of look back and see like, are these pieces covered? It's so much information that I just think, I know for myself, I really appreciated you walking through because it gives us that context, but now being able to take a look at that and make sure that we understand it, see if we have any questions, because I think we weren't really looking so much at the specifics of it as you were going through, more kind of your context.
General.
So that's my thought.
Yeah. Perfect. Thank you. Margie?
And of course, I would agree with my boss, Commissioner Porter. Anyway, however, I'm just going to say that, yeah, I was just really trying to get through and compare what we had done with what you were doing here. So it was just, I thought you did a great job with it, Melissa. I appreciate you sharing all the highlights and really eliminating all those redundancies. And I agree. It's just the specifics we just want to go through, and it may just be a little bit of tweaking, as you said. Happy to just go through that process and just finish that up and then give it the stamp of approval.
Awesome. What I can do for folks, so that because I want us to all feel comfortable doing an email vote. I'm going to make this a share doc. So and then people can go in and make their changes, and then all committee members can see the changes and who made them, so that I can then create a final document and say, here it is. This is what, please email saying, yes, you approve, or no, you don't. And I beg, if I have one request of this committee, please don't add unless it's like life or death. We have so many recommendations. So unless it's something, and if it has a high cost, if it has a huge economic impact or is very costly, take that into consideration too. Or if it's something that has very little chance of getting implemented in 3 years. So those sort of guideposts, I think, would be good. We were able to eliminate 2 pages of recommendations this time around by combining bullets and trying to get more concise. So I will do that. So I will set that up. Folks can have until next Monday to make any edits in the document. And then I will pull it down, let's say Monday at noon, send out the version to everybody, and then I'll send an email out with the final revised version asking for a reply all written vote on whatever Tuesday is. Let's see. I don't know my days of the week. I apologize. It is the 17th.
17th.
Okay, so Tuesday the 17th. And I appreciate everybody bearing with me. I know you got these late, and I just apologize for the delay in getting them out to you. All right, our last order of business, and we are going to the bitter end this time, which this group almost never does. So I don't want to hear any complaining. We're usually out early. I'm going to pop up the 2025 schedule, and we just need to vote on our meeting schedule. I am proposing we keep our standard meeting schedule the second Tuesday of the first. It's not the first month of every quarter, but the second Tuesday of March. I think we meet March, September, December, and I'm missing a month in there, June. That's the one I missed, and we do June. So let me pop up the schedule and we will just vote on that, and then everybody can be free. Okay. And this was attached to the agenda, so hopefully everybody had a chance to take a look and make sure it worked for them. Okay. So do I have we would be meeting March 11th, June 10th, September 9th, and December 9th from 10 to 12, keeping these meetings on Teams. Do I have a motion to adopt the 2025 meeting schedule?
So move. This is Amy Porter.
Thank you, Amy. Do I have a second?
Mike Santoro, Housing, second.
Okay, great. And all in favor?
Aye.
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 Any discussion? Oh, yes. Did you have a discussion, Amy? No? Okay.
No, I was just trying to figure out if you wanted us to say aye or raise our hands, so I did both.
Okay, any opposed? Abstentions? Okay, so our 2025 schedule passes. I will email that out to everybody. And our final order of business is, I think we're not going to have time to get to other business today. So, but I do want to give our partner at the Commission on Women and Children, go ahead, Michael, our Long-Term Care Advisory Council partner, an opportunity to very briefly address the group.
Yes, thank you. And thank you, Melissa, for all of your hard work. Heather, too, and the rest of the OPM team and putting this report together. Thank you kindly for that. We appreciate that. I also want to thank Christine and Mike and the rest of the DSS team for all the hard work that you guys do, day in and day out. So super grateful for that. Our next meeting of the Long-Term Care Advisory Council is on Thursday, 12/12/12, December 12th at noon. We're excited. We'll have a little bit more of a expressly enumerated presentation on the importance of oral health for older adults, including some of the stuff I raised earlier for those who would like to check that out. It'll also get posted on our commission's Facebook afterward. And we're hoping to have Representative Garibay, who's been recently reelected and also reappointed as the co-chair of the Aging Committee, come to give us welcoming remarks. So thank you all.
Thanks, Michael. All right, that brings us to the end of our time. Do I have a motion to adjourn? This is honestly the only group I've ever been part of who no one makes a motion to adjourn.
Motion to adjourn.
Okay, thank you. Who wants to second?
I'll second, Margie.
Okay, Michael made the motion to adjourn, Margie second. Happy holidays, everybody. Thank you so much. I will get that report up in a share doc, invite you all in to make edits, and we'll circulate it Monday afternoon and ask for a written vote on Tuesday. Appreciate you all. Thanks so much.
All right, bye.
Bye-bye.
Thank you.
Thank you. Thank you. Bye.